I've been thinking how to approach this session. And the reason I've been asked to do this session is because of my work on maternity experience with Jill Phillips. Whose Shoes? The board game that enables us to think about lived experience from all different viewpoints. So that of the pregnant women using our service, but also that of the staff working in a service. Whilst I was pondering how to run this event, I suddenly realised it's obvious I should do an episode of my podcast. I know how to do that. It's easy. And I can record it, and it will be of interest to people other than obstetric trainees, I hope. But it will also help you perhaps to understand what those leaders, what those consultant obstetricians are tackling day in, day out. So coming back to my question, what matters to you? It's quite a simple question really, but one we can forget to ask. The What Matters to You is a campaign in Scotland, and we've recently passed, on the 9th of June, What Matters to You Day. This is a campaign and an annual day encouraging healthcare professionals to think about asking what is important to people. This establishes a relationship between those giving and those receiving care, and immediately helps you to understand the person in the context of their own life and the things that are important to them. I remember some years ago reading a book by Atwell Gandhi, Being Mortal, which was about end-of-life care and how we look after people towards the end of their lives. And end-of-life care can focus the mind a bit. What are the things that are really important to you? Is it staying at home? Is it attending a certain family event, such as a wedding? Is it being able to eat and enjoy your food? Is it being able to retain your mobility? There are many different options, and for each individual person, what's important to them, what their priority is, will be different. So with this crucial insight, you're in a much better position to work with the person to find the best way forward for them. And maternity care is no exception to this. In maternity and pregnancy care, what is important to that woman, to that family, to that new baby? I had a look at the What Matters to You website, and I would urge you to do the same. There's a multitude of really useful resources, partly for professionals in how to have an open conversation and really give people an opportunity to say what is important to them and express their feelings about different options and how that might impact on them. But also for patients or pregnant women, there are a range of resources that can help you think about how you ask your questions and how you can advocate for yourself and the things that are important for you when you're in a situation with a healthcare professional and you perhaps feel you're not getting the support and advice that you need for the context you're interested in. Looking at the website, it also talks about levels of listening, and there's a great resource on the website, which is a short video about levels of listening. It can sound a bit stupid to ask if we're listening when we're having a conversation. Of course we are. But are we? Even if we're trying our best, sometimes we just aren't, and I find this myself. Sometimes on a ward round, a midwife is patiently presenting the information about the woman she's caring for. I think I'm listening. There may be distractions and other sounds, or I'm perhaps thinking about the woman we just left, and then I realise that I've zoned out and I haven't heard a word. In some ways, that's okay. I'm conscious that I haven't concentrated. I can politely, but rather embarrassedly, apologise and ask for the information to be repeated. But sometimes it's worse than that. I believe I'm listening. I believe I'm giving my full attention. But then I might ask a question which demonstrates that I'm not really properly listening, that I've missed some information. And that is more problematic. I may have missed a really important piece of information without even realising I have. So let's think about these levels of listening. Level 1, listening from habit. You're essentially downloading information, and you have a habit of reconfirming your opinion and judgments. So you might ask a question and expect a certain answer. Even if the person gives a different answer or unexpected response, you may adapt that. You reconfirm what your existing opinion is. Listening level 2 is from the outside. It's factual. You're noticing differences between what you're hearing and what you thought you might hear. So you're disconfirming. You're using new data. Your mind is open. Listening level 3 is listening from within. It's empathetic. You're establishing an emotional connection with a person. Your heart is open and you're seeing things through the other person's eyes. You're seeing their perspective. And then listening 4 is listening from a source. It's generative. So from the listening, seeing the future differently, you're connecting to an emerging shift in identity or ideas. I think these levels of listening are very interesting, and I would like to think that most of the time when I'm with a woman, I'm at least listening on level 3. Empathetic listening, seeing things from her perspective. And when I attend our Maternity Voice partnership, I would hope that I would be listening at level 4. My heart and mind are open. I'm thinking of new ideas. It's sparking things in my brain. It's giving me a different future, different outcome from if I had sat and done something on my own. And in my mind, this is where the work I do with Whose Shoes and the board game come into play. The lived experience scenarios and poems can help me move directly to level 3 and level 4, deeper listening, taking me straight to seeing the world through another's eyes, shifting my thinking and having those so-called light bulb moments. Some of the most exciting work we've been doing this year with Whose Shoes is around health inequality in women of different ethnic backgrounds. We've recently held a workshop led by Rosie, a midwife Darcy Fellow, doing a project in Croydon. And this work is really helping us see our services from the perspective of these women who sometimes feel marginalised or that services don't cater for them. Deep listening to these women and families will help us unpick and perhaps undo some of that inequality within our services. So the What Matters to You initiative is important to help healthcare professionals understand what's important to their patients, in our case, pregnant women and their families. But we can also apply these levels of listening to ourselves and to staff. So I'm now going to take a bit of time to think what matters to you, the labour ward obstetrician or labour ward lead. It can be overwhelming being the obstetrician on the labour ward. Some of you may be familiar with Gilbert and Sullivan. There's a fantastic song, The Modern Major General. And I'd urge you to take a look at the lyrics or play the song on YouTube if you have a moment. In essence, it lists the huge number of facts the Major General is expected to have, the skills and experience they should have at their fingertips, the immense responsibility and breadth of knowledge and ability, that they're supposed to display. And I think being a modern obstetrician can sometimes feel like this. We can be pulled in all directions, multitasking. We have enormous responsibility, not only day to day on that shift, but longer term. There are huge expectations that we will get everything right all the time. We won't make mistakes. And in my mind, I have a vision of us surrounded by plates spinning, and all the time a fear of one smashing, falling to the ground, and then the whole thing tumbling down around our ears. So, I'm going to pause and think what matters to you as the labour ward consultant. Share some ideas about how to make it more manageable. I recognise that no one size fits all, but I can tell you what has worked for me over the years in my role, first as labour ward lead and now as a labour ward consultant. One of the key aspects of the job is leadership and multidisciplinary team working. This is important. You need to lead by example. Role model how you want people to be. That can be easier said than done. We all know how we should behave day to day, but actually, can we try and do our best day in, day out when we're under pressure? It's not always easy. We're working, teaching all the time, not just formal sessions, but on a shift, teaching and supervising junior doctors, specialty trainees, but also junior midwifery staff. Anything we do, they may copy and emulate, or they may discount it and say, that's not actually how I want to be. So the negative is as important as the positive. And with this leadership comes a big weight of responsibility. Sometimes in medicine, I think we can be a little narrow-minded. And one of the things I've done is try to open my mind, try and look up and out. There are many, many books and articles and podcasts and TED Talks on leadership styles. Think about the people that were leading when you were training, or the people that you felt, I want to be like that when I qualify. But also think about the people you don't want to be like, and what were they like? What is it about their behaviour, or the way they taught, or the way they practised, whether that's midwifery or obstetrics? What put you off? And if you're reading all these ideas and thinking, share things around. I created a little maternity library in my unit. I put some books with a sticker on in the staff room and left them. And I know they've been handed around the midwives year after year. I can't tell you if they're there now, but I know every now and again someone pops up and tells me something about a book they've read that had my name on it. So share the ideas, what you're reading and what you're thinking and what you find relevant with other members of the team. Know that even though you are a leader, you're never on your own. Don't be frightened to phone a friend. Use your colleagues. They might be midwifery, they might be anaesthetic, they might be paediatric, they may be other consultants within your team. Remember that teamwork is essential. Use those relationships, forge those relationships, and understand the other members of the team. What are their roles and responsibilities? At my work, we've done a series of job shadowing or work buddying. Our home birth team leader shadowed our labour ward lead obstetrician for a shift. It gives insight into what your role is to the person shadowing you, as well as insight from you into what their role is. Most recently, I went and shadowed one of the staff in our maternity admin office to see what they had to do to ensure that bookings, scans, clinic appointments happened at the right gestation within pregnancy, and how they ensured that they were booked with the right midwife to make sure there was continuity of care. My consultant group are immensely strong. We support one another. It's never a bad thing to phone another consultant when they're not on call and get them to come in and give you a hand, give you a second opinion, fresh eyes, fresh brain, fresh thoughts. So even when you're that labour ward consultant, you're not on your own. Midwifery management colleagues or professional midwifery advocates are also your allies. Sometimes when something can get a bit overwhelming, it's great to just sit down, have a cup of tea, take a break and think, how can you manage this better together? Another aspect of being a labour ward lead obstetrician is that of guidelines and implementation of guidelines. We can be bamboozled by new nice guidance, RCOG green top guidance, or NHS England guidance. Ockenden immediate and essential actions. There's a never-ending stream of things we need to examine and check. Are we up to scratch? Are we doing the right quality? And for this, I would say, use your external networks. Stop reinventing the wheel. We're doing the same up and down the country. Use BICS, the British Intrapartum Care Society, or the RCOG, or your local maternity system networks, or your regional clinical networks. These are all formal examples of networks, but what about informal? If you look at the hashtag MatX, there are many obstetricians and midwives sharing ideas on Twitter, Instagram, Facebook. To try and help you share ideas more easily, we've actually created a whole maternity experience Fab NHS webpage where you can upload your solutions and ideas and share them with other people, as well as downloading theirs or getting their contact details. Another idea of sharing ideas more widely is randomized coffee trials. Can you have a cup of coffee with someone, either on the phone or via Zoom or Teams? Can you spare an hour or half an hour to talk to someone working perhaps in a different area of the country, or perhaps even in another country working on the same stuff? Share ideas. That will take you to listening level 4. You'll be opening your mind. You'll be thinking differently. Most people can spare half an hour, and actually through the pandemic, because of the virtual ease of meetings and the acceptance of virtual attendance at meetings, we can actually network better with people in other areas than we could ever before. Using our clinical networks to optimise care, such as neonatal in utero transfers, making sure that preterm babies are born in the right place, in the right hospital, in the tertiary centre, the place where they need to be, can make a big difference to the outcomes, long term, the health of that baby and that mother. Guidelines and implementation of guidance can be very dry, can be very boring for those of us that don't necessarily like that sort of thing. Use a bit of a creative streak. Long ago, when I was the labour ward lead and actually the clinical director for maternity, we were trying to pass our CNST level 2 and level 3. I wrote a series of unit emails sent to the whole maternity unit with popular themes such as London Fashion Week, the 2012 Olympics, popular TV shows such as Downton Abbey or the latest Bond film. I tried to appeal to people, make it a bit more interesting than that just global email that gets deleted straight into the bin. It catches people's attention, makes them more interested in what you're doing and more motivated. Think creatively. What could you do? What are your strengths? Do you like to write? One of the things doing Whose Shoes has got me to do is to blog, to record videos perhaps, and now podcast. It's so simple for you to be able to record, edit and do something yourself. What might catch people's attention? What might make things more attractive to people to get involved? And what skills do you have in your team that you could utilise? Next responsibility for most labour ward obstetricians is quality improvement, improving the data outcomes, trying to do something about the postpartum hemorrhage rate or the number of bad tears that women have experienced. How can we tackle that? In my experience, women are the hidden weapon to drive change. If women start asking for stuff, then that gradually gets staff on board. I've tried this during a caesarean when I was trying to implement optimal cord clamping, or at least a delay of some type to stop immediate cord clamping. I started telling women in the antenatal clinic that this was possible at caesarean, and then gradually women started asking for it. And I also told women that if someone told them they couldn't have it, that they could say, Florence said it's possible. So to drive a change, get women involved. They can see our blind spots. They can help us. There are some phenomenal women out there, incredibly motivated to help us make change. Lived experience is incredible for making people see what needs improvement and their desire to make sure that their experiences aren't repeated by other people. You may or may not have heard of family integrated care, the idea that parents are the dominant carers for their babies even when they're admitted to the neonatal unit. They take charge of and coordinate their baby's care with the help of the professionals, of course. Nadia Leek and Rachel Collum are two parents helping drive this change. FIC care or FIC care. Take a listen to what they have to say.
So to put this in context, my name is Jill Phillips, the creator of Whose Shoes, and Florence is talking here about the Wildcard Whose Shoes podcast series, where I talk regularly to all sorts of different people who are passionate about healthcare, and I love bringing in the voices of people with lived experience. Here is a clip from the episode I recorded with Nadia and Rachel.
Family integrated care, if you look at the definition, if you like, or what the BAPM frameworks, that's the British Association of Perinatal Medicine, have created a framework for family integrated care, which we're abbreviating to FICARE, and pretty much is used around the world. It talks about having parents as the primary caregiver to their child. So this really is an extension from family-centred care, which is very much the model of care practice throughout the UK. And many places have moved into family integrated care, but the big difference there is that the parents are that primary caregiver, and that the love and the nurture, the type of bonding that is required for the baby's brain development, is given the space and opportunity to thrive. And that can only happen with the support of the healthcare professionals on that unit, because so much of the medicalisation of your family is due to the processes and the protocols which are necessary, right? We've never questioned the medical care that our children has received. It's just how can we parent, because that's the bit that helps our babies to thrive and helps us to thrive. It helps with the breast milk, and we know the value of breast milk for these tiny, tiny babies. So family integrated care in a nutshell is about parents being primary caregivers to their children, and an ethos, a culture on that neonatal unit that supports that bonding and family.
Yeah, I see a lot like the hashtag on Twitter now, like parents not visitors, and I think that is the crux of like fee care. You don't want to feel like a visitor coming to see a baby that doesn't really belong to you. And I think a lot of the NICU environment, there are ways it's set up that is a barrier. So even like most NICU units for security, you have to buzz and wait for somebody to let you in. And I think for maybe 2 weeks after our little one was born, I was saying like, I'm here to see, rather than like, I'm such and such's mum. And I think that change in language like took a good 2 or 3 weeks, because you do feel like you're there to see them rather than you're there to be with them, or you're a complete part of that unit. And things like that, there are ways of getting round, which I think are slowly coming to the fore. So things like having a fingerprint to get onto the unit instead of having to wait and someone let you in. It's a really simple thing, but it makes a massive difference to families. So yeah, I think it's about feeling like mum and dad, basically, and not just someone on the side.
We have some really exciting Whose Shoes work coming up around family integrated care, building on the work that we've done in the MatX Nobody's Patient project, which looks at more joined up working between maternity and neonatal care.
If women demand something, then it's difficult for staff to maintain the reluctance to comply. Get involved in your Maternity Voice partnership. Any obstetrician who wants to run a quality improvement project should start there. And at least one of the obstetricians in your unit should have in their job plan to be part of the MVP. But you can also encourage specialty trainee obstetricians and gynecologists to attend the MVP and start there when they're starting with any quality improvement they want to do. If you start there, you won't waste time and energy doing something that's irrelevant, or introducing something that when you evaluate, it simply hasn't done what you expected. Co-production from the beginning. It's not simply a buzzword, it's the way forward. And have you done the 15 steps? This is a fantastic tool you can use with your MVP to walk round the maternity unit and see it in their eyes. Not how you see it, not how you walk past day after day the same stuff without noticing it, but the way a woman will see it, or a birth partner will see it on arrival. What are the things that they will notice that can be changed? And what about rewards? Over the time with MatX, we've done a whole variety of rewards, and it's amazing how a simple, small, cheap token can make people do stuff. When people are pledging at the end of a workshop, if they think they're going to get a miniature crock or a badge or a sash, they'll go for it. They'll be much more enthusiastic. We're like kids in that way. So we've used stickers, badges, sashes, shoes, all sorts of rewards to encourage action, to encourage people to make a change. And that little token that will often remind people later on to go back and do or complete whatever it was that they said they might do. These rewards accentuate the positive, make people happy, make people more willing, and draw other people in. Where did you get that badge or shoe? How do I get one? What did you do? It starts a conversation. There's a ripple effect straight away from what could seem quite a trivial resource. And rewards don't stop at staff. What about Stop and Celebrate, a fantastic campaign run to stop every time a woman is leaving the labour ward, to celebrate, congratulate her on the birth of her baby. It's a small thing. For us, it's day to day. For her, it's the birth of a new life. It might be her first baby in the beginning of her life as a family, or it may be she's taking that baby home to her siblings. She's done the best she absolutely can. It's celebrating that little moment, that major milestone in her life and that of her baby. We can spare a few seconds to stop what we're doing, turn round and celebrate with her, surely. Another responsibility that falls at the door of the labour ward lead is training. And I would say for this, you need a carrot, not a stick. It's no good telling people again and again that they must do their training. You need to make stuff fun. Food is an obvious draw. Breakfast meetings with pastries or cake or fruit. One time I just put a load of stuff on a trolley and wheeled it round, drawing people in because they wanted the strawberries that were on the bottom. And making it fun can also be doing things like the lithotomy challenge. What does it feel like to be in lithotomy? What does it feel like to be on the operating table? What does it feel like to be on the anaesthetic side of the drape in theatre? What does it feel like when you swap jobs and you go and work in the admin office or as a midwifery support worker? Switching jobs, role-playing, they give you a laugh, but they are serious in affecting change. We try ever more inventive scenarios for our prompt training. I've recently recorded a cord prolapse scenario with the help of one of our midwives with a prosthetic bump. She even made a pair of tights with a balloon inside so that we could attempt to fill the bladder in simulation to lift the presenting part off the umbilical cord. Be inventive, be dramatic. It makes it far more interesting. People are much more likely to remember your teaching and training. If it was fun, if it surprised them, it's going to stick in their minds. Try and involve more people. We've got a whole team who run our training. The practice development midwives, yes, and a number of obstetricians, but also we can drag in an anaesthetist, a paediatrician, can have a bit of a laugh. In our cord prolapse video, one of my anaesthetic colleagues did a fantastic simulation of a spinal, so much so that I even thought she might stick the midwife in the back with the spinal needle. She's now going to remember forever in her career cord prolapse. What are the important things? Because she's going to remember that day where she acted. Don't be afraid as a leader to take risks. Who dares wins. Don't be afraid to break the rules, experiment and try. Some of you may have heard of Jenny the midwife. Jenny's retired now, but she was absolutely phenomenal. She felt that skin to skin in theatre was really important at a time when not many midwives realised that. Jenny got so frustrated with the baby not being skin to skin in theatre that she took a ladder and wrote on the wall of the operating theatre, "Is the baby skin to skin?" And I'm not advocating that you go off and deface a number of walls in NHS organisations. Please don't. But she did change the status quo. In the end, the whiteboard in her theatre has a box for "Is the baby in skin to skin?" as part of the checklist. So some brave people with courage can help us all by pushing practice forward. It's okay to experiment. Try something, and if it doesn't work, try something else. Over the time I've been a consultant, I've been trying to work on the number of women feeling well supported to have a vaginal birth after caesarean. I've gone through a number of models of consultant midwife, specialist midwife, then a workshop style event, and now a continuity of care team. It's okay to try stuff out and evolve it. You don't have to have the answer right at the beginning. You can modify, try, change things, retry. It's okay to be flexible and to accept also if something doesn't work. Never mind, we've learnt from that. Let's try something different. I mentioned the modern Major General and the modern obstetrician bamboozled with the CQC, CNST, endless maternity surveys, training, MAT-NEO-QI, the long-term plan. The list is endless. But at the end of the day, ask the consultant, ask the obstetrician. One of the most important components is well-being. You can't hope to care for other people unless you care for yourself. So what matters to you, whether that is all the different things I've listed, or whether that is your actual well-being, you need to start with your well-being first. Balance is important as a labour ward lead. You need to pace yourself. Don't try and do everything all at once. Don't try and do too much too quickly. Make it manageable. And if you try and change too much all at once, it'll be too much for your team too, let alone for yourself. So you need to balance what you're doing, break it into manageable chunks, and also make sure that work isn't the be-all and end-all of your life, that you've got other things, whether that be hobbies, your family, friends, days off. What are your strategies? Well-being's a bit of a buzzword. I don't actually like it. The kind of tokenistic well-being sessions that are being run at many hospitals up and down the country. But caring for yourself, that is really important. I walk my dog. I often do a yoga video when I get home from work. A little bit of stretching, relaxation and breathing does a lot to set me right. So as you're the modern obstetrician on the labour ward with so many calls on your time and so many demands on your expertise, make sure that you think about what matters to you as well as what matters to everyone else. Now, in my podcast, I always have a zesty bit. That's the essence of what I want you to remember at the end of the day. What would my zesty bit be from this episode? I think it has to be, what level of listening are you using? Not only for the women using your service and the families that you see day in, day out, but also for your fellow staff. Are you really listening? Are you really imagining the world from their viewpoint? Are you asking what matters to them and thinking how you might prioritise those things, what changes you could make that will be most meaningful? And when you listen to women, are you really understanding what matters to them? And last but not least, do you understand what matters to you? As you move through your career as an obstetrician, It's taken me time to understand what's important to me. Yes, the day-to-day is. Yes, the birth of babies is amazing and extremely rewarding. But I know that I need a bit of creativity. I need something outside the job. Hence the fact I started a podcast. So understanding what matters to you yourself so that you can get the right balance at work, so that you can sustain yourself as a consultant obstetrician and lead people effectively on the labour ward is very important. For the rest of today's session, we're going to look at a small number of cards from the Whose Shoes board game together, which I'm hoping will prompt a little bit of thought. It's a bit difficult running this session because I can't have that much interaction with you. Normally at a Whose Shoes workshop, we would sit down in multidisciplinary groups with plenty of women and families that have used our service, hopefully lots of babies present, and we'd spend 2 or 3 hours having discussions prompted by scenario cards and poems. People would write down on post-its their ideas and thoughts about solutions to problems, what they might improve to make things better. And at the end of the workshop, we would ask people to pledge what they might do differently as a result of the day. The workshops are energetic, buzzing, exciting, and above all, fun. So I'm going to show you a short video which hopefully captures the feeling of what it's like to be at one of these events.
The other babies are choosing on the day.
And that's where the teamwork comes in.
Speak up when I think positive change can be made.
The board game works with different views from different perspectives. Blue are women and families. Yellow are frontline staff. Red are commissioners, managers. And green are charities, third sector, perhaps antenatal classes. I've chosen a single card from each of those categories, which I'm going to read and which we can think about together. Hopefully these will help you get into that level 3 listening, imagining you're in that person's shoes and imagining what you, as the labour ward obstetrician, could take away and think about. I'm going to start with green. Home birth. It's all very well saying women are being offered choice, but this depends far too much on how choices are described to people. Mums are not normally ill, so why should they go to hospital? Birth is a natural event. Perhaps home birth should be the norm rather than the exception. I'm hoping that this card will make you think a bit about home birth. We know from the birthplace study there is a large amount of evidence that suggests for multiparous women having their second or subsequent baby, in a developed health economy that home birth is actually the safest option for that woman and has no significant difference in outcomes for the baby. I like this card because it works with the idea that home birth should be the norm rather than the exception, which flips on its head what currently is happening. At the moment, if you're going to have a home birth, you opt into home birth. But could we think about it differently? Could we reimagine it and think you have to opt in to hospital birth? What would that look like? What would that do to our services? And if you don't want to be as radical as that, you should at least think as an obstetrician how you're going to support home birth. Home birth needs a home birth team, but it also needs partnership with obstetricians. When things do start to deviate from the normal and a woman needs transfer into hospital, she needs timely review by obstetricians, often in an emergency situation. Having good working relationships and clear guidelines for the home birth team to operate within and to work together and to perhaps simulate some of those skills drills in a home situation is essential to improving and increasing the home birth rate. So I've included this card because I would like you to think and question, what are you doing with your home birth team? Do you know your home birth team? Have you been out with your home birth team? Do you know what their practice is like? Do you know what their transfer rates are? Do you know if they feel well supported by the obstetricians in your unit? Do you have a designated home birth lead obstetrician? And what could you do in your practice that would help women that are uncomplicated, that don't have risk factors, understand that perhaps home birth is the safest option for them and safer than coming in to our hospital? The next card is blue. Ward rounds. When I was in labour, the consultant walked into the room with a whole crowd of people to check how I was doing. I know they were all there to help, and students have to learn, but I felt surrounded and it was really intimidating. This card is important because a ward round is something we take for granted. We go in, we want to meet the woman, we want to put a name to the face, we want to understand the story we've heard at handover and talk to that woman. But we're interrupting her labour. So we need to think about strategies. Do we all need to go into every room? Could we delegate, have a conversation, some of us, but only some of us go into the room? But that's talking about a woman without her, which also doesn't feel right. We could ask the woman what she feels. Would she like the ward round to come in or not, and give her a choice? Would she like to meet the doctors as a matter of routine? Are there some rooms on the ward round that you perhaps don't need to go into? If things are uncomplicated and the woman's labour is progressing, could you leave that woman out of the ward round? Do you warn the woman that you're coming in on the ward round? And do you give her a choice about how many people come in, whether it's just one person or whether it's a whole crowd? How do you introduce yourself when you come in on the ward round? I try and get the woman's name right so that I can come in and say, hello, Rachel, for example, my name's Florence, so that it's really clear that this is about her and that I know who she is and I'm treating her as an individual, as a person, by name. Who's on your ward round? Do you have your anaesthetic team come on your ward round? We do, and that can be very helpful when you're reviewing a woman perhaps with severe preeclampsia or who might be considering an epidural, or a woman who already has an existing epidural to check it's working effectively. That also might mean in an emergency situation she's met the members of the anaesthetic team. But giving a ward round some thought and not just doing a ward round for the sake of doing a ward round, ticking that CNST box that the consultant has been round and reviewed everybody, thinking of the purpose of the ward round and how that ward round impacts on the woman is really important. Rather than doing the ward round at your shift change or 8 o'clock when you come on, could you do it at a time that works for the woman? Perhaps she's having an examination at 10 o'clock and she's sleeping at 8. Could we leave her to sleep and see her when she's awake at a later point? Or at a point when a decision actually needs to be made about her plan of care? So understanding and being less rigid about our ward rounds and thinking a little bit outside the box for our ward rounds, I think is a really important topic. Red card. Taboo. As I learn more about cultural issues, I'm starting to see big gaps in services that are provided, including sometimes by charities, as people are simply slipping under the radar. There are many taboo subjects such as mental health, so it can be hard for women to talk about how they're feeling and to seek help. This is compounded when the mental health problems are caused by birth trauma or baby loss, which can be taboo subjects in themselves. This card is really interesting to me. We're starting to get much better at talking about topics such as baby loss or birth trauma, I think. But we know there are very disparate outcomes for different ethnic and cultural groups. Are we making sure that when we make changes and try and improve services, that we're really thinking about perhaps cultures that won't necessarily fit in to our ideas of how we might manage in that sort of situation? An immediate thing I can think of is bereavement care. Given that we know that unfortunately there is inequality and women from some ethnic groups are more likely to experience baby loss and be bereaved during pregnancy, how are our bereavement services catering for these women and families? We will be asking people for permission for a post-mortem. Do we know how difficult that is for a family, perhaps Jewish or Muslim, who need to bury that baby within 24 hours, according to their cultural and religious beliefs? Do we understand how different cultures experience and process baby loss, and how it will be discussed as a family? And is it discussed at all? And what about birth trauma? If we see things in our framework about what our expectations were of birth, are we understanding correctly what someone else's expectations were and perceptions were of how they feel as they enter motherhood? If we see everything through our lens, we may fail some of the diverse population that we serve. So we need to make sure with everything we do, but especially with some of these difficult situations, that we cater for everybody and that we're getting feedback from those families that perhaps are less vocal or we haven't thought to ask. Maybe staff members from some of these different communities can help educate the rest of us as to what they feel are the relevant issues for their culture or background. We need to examine and absorb the recent 5 times more publication of Black women's experience of maternity care and apply that learning and those messages to our own services where relevant. We can use our MVP to go out and talk to community groups and try and gather feedback in that way, not expecting those groups to always come to us. And we need to look at what evidence is already out there. Do have a look at the Patient Experience Library, which collates all sorts of reports from Health Watch and many other organisations about patients' experience of all sorts of NHS services on their website. Some of it's maternity related, some of it isn't. And one of the things I think that's important when we think about some of these taboo subjects is what can we learn from other areas of the hospital or primary care, because some of the issues will be the same. Finally, your yellow card. Ockenden. I recognise we need to learn from the shocking and devastating stories from Shrewsbury. But with current staff shortages and 15 immediate and essential actions to implement, I really don't know where to begin. We're all feeling a bit daunted at the moment. It's very difficult as a profession to come to terms with some of the dreadful events. Yes, we need to take responsibility for those actions, but we also need to understand that there are systemic issues here. In the launch of her report, Donna talked very clearly about 4 key pillars. 1. Safe staffing levels. 2. A well-trained workforce. 3. Learning from incidents. 4. Listening to families. She also clearly wrote about creating a culture where staff feel safe and supported to speak up. Psychological safety of all staff is essential if we're going to implement all these immediate and essential actions well. At the moment, it's very difficult to maintain staffing levels. We all know the challenges we have faced with COVID. High sickness levels either from the virus itself or burnout. We also know that we have a national shortage of midwives. This makes it very difficult for obstetricians and midwives alike. We've also got considerable rota gaps in our O&G workforce. So, safe staffing levels are something that you're going to have to work on with your clinical director, with your service manager, making a case on the back of Ockenden, arguing for investment in your local maternity service. But some things are more within our control. A well-trained workforce. That means CCG teaching. That means skills drills. That means a team that work together and train together. Simulations. And yes, it's hard not to cancel study days when we're under pressure. But understanding and remembering that a well-trained workforce and giving that workforce time for training and valuing that training means we're also valuing those staff and supporting them and giving them the right skills they need within the system so that they're not feeling alone, isolated, and to blame when things go wrong. We need to learn from incidents. It's truly shocking when you read some of the Ockenden report as to the complete lack of learning. Most of us would like to feel that that's not the case in our unit, but really truly learning, discussing cases, appreciating that not all bad outcomes are due to negligence, but are usually due to a catalogue of things going wrong, one after the other, the Swiss cheese model that we're also familiar with. And learning not just as individuals from incidents, but learning what are the things we can put in place to make those mistakes by staff less likely to happen. And finally, and fundamental to everything else, is listening to families, listening to their experiences, both good and bad, taking on board their feedback, seeing it as useful and constructive and not critical, and absorbing what we're told and opening our doors to those families, whether it's via the Maternity Voice Partnership or other forums, so that we have a developing collaborative co-production improvement relationship, a dialogue with the people that we're caring for, as well as the staff working with us. So when you're struggling with your 15 immediate and essential actions, sometimes it's best to go back to those 4 key pillars and think you cannot achieve everything all at once. You have to take it step by step. But are you underpinning what you're doing with those 4 key principles? I'm going to end the session with a poem. A very important meeting. The staff are all busy, rushing about. Room 3 is pushing, I hear someone shout. A midwife rushes in, her presence is fleeting. She mutters something about going to a meeting. A meeting! I put my arms round my wife, contemplating, anticipating the most important meeting of my life. I chose to end with this poem because at the end of the day, this is what it's all about. It's about birth. It's about a new person entering the world, meeting their parents for the first time, and creating those parents and new families. Sometimes we need a little reminder that our day-to-day is made up of these profound, precious moments. I hope you found this an interesting session. I've put some links in the chat and I'm going to ask the college to share those links with you after today's event so that you can follow up on some of the topics I've talked about. Many maternity units up and down the UK have the Who Shoes card set and board game, and now that the pandemic is hopefully on the wane, it's time to get out those cards, think about them with your teams, and start some of this more creative work, re-energising ourselves and those we work with, and getting back to what matters to you, but also what matters to us. Thank you very much. I hope you found that an enjoyable and entertaining session. And do please have a listen to some of my other podcast episodes. The Obs Pod can be found on Apple, Spotify, and any of the major podcast platforms.